Hi, I'm Dr. Barbara Cockrell. This is the second in the series of videos explaining our new assessment system of clinical skills at Harvard Medical School. A major change was the incorporation of Entrustable Professional Activities, or EPAs. In this video, I'll interview Dr. John Dalrymple, Director of Clinical Skills Assessment at HMS, and Dr. Ed Hunnert, who is the HMS Dean for Medical Education, to further explore and explain the rationale, background, and structure of the EPA system. Before we get started, I wanted to go over exactly what an EPA is. How do we define it? An EPA, or Entrustable Professional Activity, is an integrated part or unit of professional practice. EPAs define the tasks or responsibilities that all medical students should be able to perform by the time they graduate without direct supervision. In other words, EPAs are activities or skills that all interns should be able to perform on day one. Can you talk a little bit about and explain exactly what an EPA is?
An EPA, as you mentioned, is an Entrustable Professional Activity. The AAMC several years ago suggested this framework for medical schools to consider in their education of students. And at HMS, after many meetings and deliberations, we actually came to the conclusion that this was a great framework for us to adopt and modify for our project. So the core EPAs are entrustable professional activities or skills that students of medicine should be able to perform by the time they graduate from medical school.
How is that integrated into our system?
What we've done with the Committee on Assessment is that we've taken the 13 EPAs as recommended by the AAMC, and again, we agreed that they were all really relevant to our curriculum at HMS and determined where are they best taught and therefore initially assessed in the 3 different phases of the curriculum. And therefore, that is the earliest time in the medical school curriculum that we can assess them. Moving into the second year, the PCE year, we now can layer on another series of EPAs that actually reflect what happens in the clerkships.
This slide shows a list of the EPAs we are using at HMS for student assessment. You can see that these entrustable professional activities describe 13 activities that all medical students should be able to perform upon entering residency, regardless of their future career specialty. For ease of assessment, HMS divided EPA number 1 into 2 items: gather a history and perform a physical examination. As Dr. Dalrymple mentioned, the EPAs are mapped to the point in the curriculum where they can be assessed.
I think there's a parallel in the fact that the residencies expect our students to come out of medical school with these EPAs under their belts. In a way, the clerkship directors in the PCE year should be expecting the students to come out of the practice of medicine course with those first 5 EPAs under their belt.
Key to the concept of entrustability is the level of supervision at which you would consider a student entrustable. Can you talk a little bit about that?
The level of supervision is critical to entrustability in an EPA. As a student learns an activity, they progress from not knowing anything about how to perform that activity all the way to the ultimate level of being able to teach someone that skill. So as an example, if you think about a student who is just learning how to appreciate the sterile field, they are unaware of what sterility is and may often contaminate the field. In that case, a student needs intense direct supervision. Over time, as a student learns how to actually perform sterile technique, how to scrub and gown, slowly that supervision is lifted to the point to where they can do it unsupervised and then ultimately even be a teacher to more junior students. What's interesting is that students progress at different rates, and so we wouldn't necessarily expect that all students to be entrustable at the same time. Again, one of the hallmarks about competency-based medical education, that each student reaches competence at their own pace, and with that in mind, we can really tailor and personalize their education based on how they're progressing.
And even each student progresses along the 13 EPAs at different rates. I think in each of the 13 EPAs, the assessment committee did a huge amount of work trying to anchor a description of what a pre-entrustable, an emerging, and an entrustable student looks like, so that people could look at that and say, okay, I get what that means, and I can give the student really useful, actionable feedback.
The first place will be that we've used the EPAs is in the PCE. So where do you expect most students to be in their second year of medical school?
We would expect that most students are going to be in the emerging category. Having said that, students do progress at different rates, and some may be pre-emerging, some may be emerging, getting close to Entrustable. The key part, though, is that we want to see sustained performance at that level, and so it requires multiple opportunities for direct observation by clinical faculty and residents to make those sort of determinations about which stage they are in their development.
That'll be a difference for a lot of faculty, because if you have a really fantastic student, you're used to giving them the highest mark. But this sounds very different.
It does. And this is one of the big changes about our grading and assessment system, is that when we talk about our fantastic students, which there are many, the question is, what are they fantastic at? And so we really have broken it down to specific activities. And when you break it down, we realize that some students are more advanced in certain domains than others, and we want to be able to recognize in which EPA or which skill the student is doing well at. So as a consequence, we really can track and monitor students' progress. It really allows the students and the faculty to think about the student in these different areas.
Helps the students get the kind of feedback that they really want and need. You know, if a student does a case presentation, I think in the previous framework, a student would hear from their faculty member, that was a fantastic presentation. Well, that's not actually that helpful. It's a compliment, but it's not actually feedback, right? So what we're trying to do is have a dialogue where we say, well, what exactly about it made it fantastic? So I could do more of that. Is there anything that could make it even better? That's the quality of feedback that we're hoping to engender.
Another key component is direct observation of these clinical skills.
Barbara, that's one of the most critical foundational elements about the clinical assessment program and in any framework, but certainly in the EPAs. Without direct observation, we really cannot say much about the student's performance. We can easily infer how a student is doing based on a conversation or listening to them present a case, but that really is just a case presentation. It doesn't really tell us how their history-taking skills were. If we didn't directly observe them, then we really can't comment on how they got that information. How did they engage with the patient? How did they structure that history? Was there empathy? Was there cultural competence involved? Did they act in a professional manner? That's all wrapped up in taking a history. So the direct observation of a student by faculty and residents is essential to how we assess students. And I think using a framework such as the EPAs allows us to really hone in on those specific skills in a meaningful way.
Some faculty may be concerned that they haven't had adequate direct observation in order to evaluate a student. How are we dealing with that?
It's an excellent point. This has been an ongoing problem. It's not new to this framework that we've introduced. What is essential is that the observation of the student, even if it's for a short period of time, should be based on what the EPA was all about. So for instance, if I had a student in my clinic for half a day, I might only be able to make a commentary on a couple of observed histories or maybe a focused physical exam, and that's about it. That's only 2 out of the 13 EPAs. I cannot make a global assessment of that student, but I can make a comment about those 2. It's important also to recognize that we are not asking individual faculty or residents to grade or assess the students. We're asking for feedback on their performance, and that rich feedback on direct observation is invaluable to those who are making the overall assessments of the student's performance.
How does this new system align with national practices and recommendations from the AAMC?
Since the AAMC introduced this framework several years ago, medical schools across the country have been looking at how best to adopt this into their curriculum. Here at HMS, again, we recognized early on the value of incorporating such a framework, and we decided to adopt the entire program, of course modifying it to our needs. I would say that we are certainly at the front, if not leading, in terms of our adoption and integration of the EPA framework into our entire medical school curriculum.
How does the use of EPAs for medical students,
relate to what is happening in internship and residency?
It's an excellent question. This large movement to competency-based medical education has already evolved into residencies. So milestones are incorporated across all programs in graduate medical education. With the incorporation now of EPAs into undergraduate medical education, students are being exposed earlier on to this framework. So it really is a natural transition and continuum from medical school into residency.
Yeah, I think it'll make it much easier for our students to get used to this idea of being assessed for different competencies when they get to residency, for having had that experience from the first years of medical school.
You've mentioned milestones and competencies. How do the EPAs relate?
That's a very good question, and there is often confusion about EPAs versus competencies versus milestones, and they're basically all wrapped up together. When we think about milestones, and certainly most people are familiar with milestones as it relates to GME assessment, milestones are just a different way of thinking about EPAs. As far as competencies go, EPAs require competencies in order for them to exist. So when we think about the EPA of taking a history, that requires the competency of medical knowledge, it requires a competency of patient care, it requires a competency of professionalism, and the competency of interpersonal communication skills. Without those four competencies, you can't take a history.
How were students involved in helping us with the new assessment system?
We have sought their insight and opinion on the different frameworks and our approach to these changes. We find that student input is invaluable, and we certainly want to make sure that they understand the rationale and have a chance to provide input to these new programs.
Yeah, I think some of the early meetings where we actually gathered students from different years, including students who were in the new curriculum, students who were in the outgoing curriculum, and asked them about these issues. A lot of what we learned was from the interaction between the students in the different years.
How's it been going so far?
It's been very exciting. We, just this past year, rolled out the formal EPA-based assessment system in the PCE. So for the students in the new curriculum who entered in the fall of 2016, all of their clerkships were EPA-based, the assessments were EPA-based, and the grading schema was changed to satisfactory and unsatisfactory.
The feedback so far has just been really wonderful. The students who are in this system are very enthusiastic about the focus on the learning. I think the most important thing I would say in conclusion is that this is an evolution. Like everything we're doing, we're committed to continuous quality improvement. So we're going to be looking at outcomes and probably making adjustments in future years.
For more information on the HMS assessment system and EPAs in general, please visit these websites.